Kathy Knipfer, instructor for Nursing 2203, recording the Pediatric lecture for Chapter 30, Pain Assessment and Management in Children. The causes of acute pain in children could be medical procedures, surgical and orthopedic procedures, medical treatments, injury, infection, and also exacerbation of disease-related pain. There are many pain rating scales available for rating pain in children. In your textbook, there are many examples that are included in the tables. Behavioral scales are used for the preverbal period and for those with limited communication skills. They would measure distress behaviors like vocalizations, facial expressions, and body movement. Physiologic parameters can also be used to evaluate pain, and then self-report for children above the age of 4. The most commonly used behavioral pain measure is the FLAC. It measures facial expression, leg movement, activity, cry, consolability. There are other measurement tools that have been developed, say by recovery room nurses. Some tools measure postoperative pain. Some are specific for the critical care setting. The FACES Wong-Baker scale consists of 6 cartoon faces that range from a smiling face for no pain to a tearful face for the worst pain, and that's the Wong-Baker scale. There are other scales such as numerical rating scales for children age 8 and over, and then the visual analog scale. When assessing pain, you would want to ask the patient or parent to make a global judgment of whether there was improvement and whether there was satisfaction with the treatment for pain. You would also want to assess for adverse events and symptoms, such as constipation, which is the most common adverse event. You would also look at physical recovery. Maybe the pain management regimen is not effective enough to allow for optimal recovery. And then you would also look at the emotional response, such as anxiety, depression, fear, unhappiness, and distress. Chronic pain is pain that persists for 3 months or longer than the expected period of healing. The most common chronic pain conditions in children are complex regional pain syndrome and chronic daily headache. A multidimensional rating scale should be used to measure the physical functioning, which is focused on ADLs, emotional functioning, which measures anxiety and depression, social functioning, as well as school functioning. This pain tool allows the pediatric patient to color in the areas where they are having pain. There are other pain assessment tools available to evaluate pain in specific populations, such as children with communication and cognitive impairment. An example in your textbook is the Non-Communicating Children's Pain Checklist. Also, the Pain Indicator for Communicatively Impaired Children, PICIC. It distinguishes between pain and non-pain. It has 6 core pain cues, such as crying, with or without tears, screaming, yelling, groaning, or moaning, screwed up or distressed looking face, body appearing stiff or tense, and difficulty in comforting or consoling, and also flinching or moving away if touched. These items are rated then on a 4-point Likert scale. Cultural differences should be considered. The cultural background may influence the reliability of pain assessment tools. For children with chronic illness and complex pain, the family should be asked about the onset, duration, pattern, effectiveness of treatment, what else has been tried, factors that aggravate or relieve the pain, interference with sleep, function, mood, or family interactions. Here is the Non-Communicating Children's Pain Checklist, the postoperative version, which is found in your textbook. Non-pharmacologic measures are very important in managing the pain for the pediatric patient. They include distraction, relaxation, guided imagery, cutaneous stimulation, containment and swaddling, non-nutritive sucking, such as with a pacifier, and Kangaroo Care. You can refer to those guidelines on page 841 in your textbook, which includes general and specific strategies. Here is an example of Kangaroo Care. There are other complementary and alternative medicine measures for managing pain. They can be biologically based, such as foods, supplements, herbs, vitamins, and special diets. They could be manipulative treatments, such as massage, chiropractic, or osteopathy. They could be energy based, which would be bioelectric, magnetic, pulsed fields, alternating and direct currents. Also, mind body techniques, which would include relaxation, spiritual healing, hypnosis, and mental healing. Also, alternative medical systems, such as naturopathy, homeopathy, and acupuncture. And of course, there is also pharmacologic management with things like acetaminophen, nonsteroidal anti-inflammatory drugs, opioids, co-analgesia or adjuvant analgesia with things like diazepam, midazolam, tricyclic antidepressants, anti-epileptics, and antiemetics. The patient also might undergo patient-controlled analgesia or epidural analgesia. Other methods of pharmacologic management of pain include transmucosal and transdermal analgesia. The nurse should monitor side effects such as respiratory depression, decreased peristalsis, pruritus, tolerance, and physical dependence. It's important to wean if the opioids are administered more than 5 to 10 days, and that's to avoid withdrawal symptoms. The nurse should evaluate the effectiveness of the pain regimen. The regimen should be evaluated 15 to 30 minutes after each dose, and dosages should be titrated as needed. Then the nurse should also make other recommendations. Consequences of untreated pain would include physiological indicators. They might be increased heart rate and blood pressure, or a decreased O2 saturation. What are the behavioral indicators of untreated pain? They would be muscle rigidity, facial expression, crying, withdrawal, and sleeplessness. Let's talk about common pain states and pain in primary care, as well as painful invasive procedures. For primary care, for teething, benzocaine, cold or frozen teething rings, hard crackers, and bread can be helpful. For immunizations and vaccinations, warming the injectate, using lidocaine as a diluent, applying ice and pressure to the site immediately before. Also, topical analgesia, distraction, bubbles, music, and stories. For common childhood illnesses, ibuprofen can be helpful with things such as otitis media and pharyngitis. Also, viscous lidocaine can be helpful for viral infections of the mouth. For painful and invasive procedures such as circumcision, lidocaine gel can help ease the pain. For open wounds, bupivacaine onto the dressing can be used. Nitrous oxide can be used for children over 3. Of course, it's best if they're a little bit older, say over 5. It involves 2 minutes of inhalation. This can lead to expansion of air pockets in the bowel, chest, or cranial cavity, so it would not be appropriate if someone has a pneumothorax or a bowel obstruction, abnormal airway, or even a recent head injury. Other common pain states include postoperative pain. So associated with surgery, preemptive analgesia is important. And that's where the medication is administered before the child experiences the pain or before surgery. Also post-op NSAIDs, around-the-clock opioids, PCA, epidural administration of local anesthetics such as bupivacaine with a low-dose opioid such as fentanyl, or just a combination of medications. For burn pain, there are multiple components. It's a difficult and challenging situation to control. Often fentanyl is given because it's short-acting. Maybe oral agents would be given for less painful procedures. Possibly benzodiazepine would be given before a procedure. And then don't forget about the psychological interventions such as relaxation, hypnosis, biofeedback, guided imagery, distraction, and enhanced coping skills. More common pain states. Recurrent headaches may occur because of tension, dental braces, weakness of eye muscles, sinusitis, epilepsy, sleep apnea, or injury. The nurse should teach self control skills to prevent the headaches, such as biofeedback and relaxation. The nurse can also help to modify behavior patterns that increase the risk of headache, and this can be through the use of stress management techniques. Recurrent abdominal pain is common in children. Often there is no organic cause. Parents should be trained on how to avoid reinforcement of sick behaviors. School attendance should be required. Healthy behaviors should be rewarded. Relaxation techniques can be helpful, and also increasing dietary fiber can be helpful. There is also pain associated with sickle cell disease. They may be taken to the emergency room for opioid treatment. Sometimes they're admitted and sometimes they're placed on PCA. But then those doses should be tapered if it goes on for more than 5 to 7 days. With cancer, the most prevalent symptom is pain. They also might have oromucositis, which is ulcerations in the oral cavity and throat. This occurs with chemotherapy and radiation therapy. About 40% of the pain is associated with procedures. Morphine is commonly administered, possibly tricyclic antidepressants such as amitriptyline, possibly anticonvulsants such as gabapentin, and then possibly ketamine along with benzodiazepine. Regarding pain and sedation in end of life care, comfort can be relieved with a combination of opioids and adjuvant analgesics.